All right, I think we'll get started. Welcome, everyone. My name is Helen Healy. I'm a neonatologist, and I recently had the pleasure of starting to join Noelle and Matt in planning this webinar series. Today, we are excited to bring you our next webinar called Research to Advance the Tiny Baby Care. We have several wonderful speakers with us today. We are joined by Stacey Peart from the University of Melbourne, Cheryl Battersby from Imperial College. As for moderators, Helen McDermott will join also from Imperial College. We also are joined by Kashif Ahmed, Brian King, and Dr. Roger Soule. Before we get started, there's just a couple of our usual housekeeping items. This webinar is recorded. The recording will be posted to the Tiny Baby Collaborative website relatively soon afterwards. This is multidisciplinary. We have a number of families that are also invited to join. And just as a reminder, please use the Q&A, not the chat, for questions, and we will address those discussions at the end. I'm now going to turn it over to Matt. Oh, sorry, one more slide. We do have some upcoming webinars. These are the remaining three scheduled for the rest of the year. In March, we will have on the 19th, adrenal insufficiency and hydrocortisone use. In May, a webinar on establishing a tiny baby program, and over the summer, we will have a specific webinar on nursing care. And with that, I'll turn it over to Matt for some further announcements and to begin the webinar.
Hi, thank you, Helen. It's my pleasure to be able to talk with all of you today. Thank you for joining us. As a reminder, in addition to the webinars, our collaborative also meets at the Pediatric Academic Society. We have arranged a program this year. The focus is on hearing directly from people with lived experience, the real experts. So we'll be getting together with patients and families. You can see the time and the date here. We'll be sending this out on our emailing list this next week. But if you're coming to PAS, we'd love to see you in person. Please stop by and introduce yourself. And I'm also very happy to announce, and very fitting for today's topic, PAS for the first time has recognized this as an area of needed research. So we have not the Tiny Baby Collaborative, but Pediatric Academic Societies in the field of neonatology has a section here with oral abstracts and posters focused on original science related to the care, the physiology, the epidemiology of babies born at less than 25 weeks. Please show up, support our researchers, learn from them, hear what they're doing. I'm really excited for these sessions. So today, I'd like to give a little background and an introduction before our speakers talk. I think that it's really important that we talk about research. And I realize that this is a slightly different topic than we frequently cover when we have these webinars. We'll continue to have discussions, like Helen said, the next meetings about hydrocortisone. You know, what do we know about it? How are people using it? We'll dig a little into the physiology from some older studies. But all of this, all of our discussions when we get together, when we bring experts together to talk about management, is rooted fundamentally in the research that we do. Empirically, these are the things that we learn. This is the basis for our science, for our clinical practice. So I'm very happy to see that we have folks really from across the spectrum coming to listen and talk about research. We need all of your involvement, neonatologists, but also nurses, nurse practitioners. We have a large group that identified as dietitians. We have some people who are just researchers outside of this. And then the other category contains folks from industry, folks who are allied health professionals who are not listed here. We're happy to have you. About close to 2/3 of our attendance comes from the United States. We have another really large group today from the UK, others from Canada, and from several other countries. The reason that we put on today's talk is that, as you know, we have not enough research to support the care that we provide. We've done this systematic review. Leanne Pavlik and our group put out a few years ago a look at every single clinical trial that had been published between the years 2010 and 2019, so a decade's worth of work. We conducted over 200 clinical trials that involved extremely preterm infants. Kudos to neonatologists. That's a great accomplishment. We enrolled over 32,000 babies around the world. But just a drop in the bucket, fewer than 1.5% were less than 24 weeks. And that really creates a gap. I think it's fair to say, summarizing what we found and what others have found, Stacey Peart will talk a little bit about her work in this area. What we know about caring for extremely preterm babies, trials of extremely preterm babies, are really trials of babies born at 25, 26, and 27 weeks, occasionally 24 weeks. And so it's up to us to put together the research for sound, safe, and effective practice. We were happy to see that amongst the folks who registered for this webinar, about a third said that they had at their institutions studies that involved babies born at or before 23 weeks. That's great. We need you guys to do that. We also asked, what are your challenges? What barriers do you see in conducting this sort of work? The number one thing that was listed was small sample sizes. We have low numbers. There's only a few of these babies at any given site. That's why we're here today to talk about this. It's only by working together, because we all have this problem, that we're going to be able to conduct these studies. But they're needed. And we really believe that our babies born at the earliest gestational ages have the same right to safe and effective care as all of our other patients. So we don't think that this should be an ultimate barrier. We think that we should overcome it. Other things that came up when listed as challenges, concerns about parental consent. I get this one. This one's really hard. We just had a conversation with mom, with the parents. We were discussing sometimes whether or not to proceed with providing intensive care. And then imagine saying, okay, we made this tough decision. And by the way, we're not actually sure about some of these fundamentals of management. Do you mind signing this 10-page legal form so that we can conduct this research study? That doesn't seem like the right time. In fact, parents in our focus groups locally here and in our work have told us that's not the right time. We shouldn't be having that conversation. We got a lot on our plates. So I think that that is a real barrier. I do think, however, that that doesn't need to prevent us from learning. And we need to work with our families and our former patients to learn how to best do this. I'm really excited about the PAS get together. One of the topics that we'll be discussing with families is how to improve research, how to best engage with them in those particular circumstances. Other folks brought up what I'll kind of broadly call ethical concerns. Maybe it was that they thought the IRB wouldn't approve. Sometimes it was, hey, we have really vulnerable patients. And to that, I would say they're vulnerable no matter whether you do the research or not. And I think it's really up to us in advocating for our patients that we need to argue that they have that same right as all of our other patients. In fact, I would go so far as to say providing certain aspects, many aspects of our intensive care outside of a research study is actually still experimental. That's because we do not have a sound basis for scientific practice. This is one reason we see such extreme variation. And so sometimes the question is, if it's going to be an experiment, should we be doing the informal, unassessed experiment? That is shooting from the hip, just guessing our best guess, because we think we should do something. Maybe we heard Iowa does this, or a center in Sweden does this, or a center in Japan does this. We'd like to pull it out of our pocket and try it. That's an informal, unassessed experiment. Or maybe it's we should do the formal assessed experiment, where we have a protocol, where it's well established, where we've maybe talked to the parents about it because it's a formal study, where we have safety monitoring, where somebody looked over the protocol before we did it, and we had experts weigh in and decide, yeah, this is the way to do it. If it's my child, I'd prefer to do the second. Other people brought up really common issues in a lot of research: funding, resources, staff time, and workload. Some people mentioned that there's so much practice variability, it actually makes it kind of difficult to study some things and their effects because the ecosystem, so to speak, between centers vary so much. Few people mentioned lack of equipoise. And a number of people, about 1 in 20, 1 in 25, mentioned that it's a hard population to study because outcomes, including mortality, um, are different than in some populations. I think all those are very legitimate challenges. As a result of facing some of those things of myself, and as a result of some of my colleagues facing some of those things, several years ago, we got together to start the Tiny Baby Collaborative. It was really about many of those barriers, in particular the small sample sizes, that we got together to say, look, we think that working together, we can make better, more informed decisions. We can do some of these studies. We can have a sound basis for safe and effective care. You're here, you probably know a little bit about the collaborative, but I would like to just give a few words on what we do, who we are, before I turn over to our speakers. So we really orient around three ideas. The first is that we need to understand how the most immature infants are not just extremely preterm infants. We do this in part through some of our research, sometimes by synthesizing evidence that's already out there. We generate evidence to support safe and effective care. And finally, but most importantly, we engage with our families to find out what do they need. You've maybe been to our website. You can learn more there. We have 53 hospitals now in 8 countries. If you and your center are interested in contributing to the collaborative, we would welcome talking with you. You can go to the contact site on our website. There's a link that says contact and put in your information. We'll get back to you. Right now, we run an observational registry of all of the babies in our participating NICUs. We have over 2,200 NICU stays with complete data and some real fine things like which size ET tube were we intubated with and how many attempts, the sort of things that we think are really relevant to this population, just for babies at 23 weeks or younger. We're also now conducting what is, to my knowledge, the largest clinical trial ever conducted in tiny babies. It's the humidity study, looking at different environmental conditions in incubators. This has been a partnership with families. We have family representatives across 8 of our sites, partnered with the PIs, and it's been a wonderful experience. You might see some of our work. We just finished having accepted a series of 10 articles, reviews in the Journal of Perinatology. Lots of site visits. Folks have contacted us to do this sort of one-on-one learning. You know about the webinars because you're here, and then family engagement. What does it mean to be in the collaborative? Some of you are, many of you who attend the webinars are not. But just to be very explicit what that means, hospitals or institutions participate in the collaboratives, not individual card-carrying members, but rather institutions that can meet the following criteria. Institutions demonstrate that they have very strong connections between neonatology and obstetrics. This is a continuum. We need to recognize the extraordinary importance of working together with a different specialty that really has a huge impact on the care of our babies. And we'll hear a little bit more about this from some of the details from Drs. Peart and Battersby and McDermott today. We have an obligation for follow-through. So we make sure that our babies are receiving specialized care after they leave the NICU. Our institutions have a commitment to integrating families into care decisions and practices. Importantly, they also share data with us. So they all participate. That's a criteria of participating in the collaborative. They all participate in the multi-site inventory of neonatal perinatal interventions, the mini study. And then they express a willingness, on a voluntary basis to participate in some of the other initiatives that we have, such as the clinical trial that's ongoing. And finally, They show up. It's a wonderful community of people to meet and engage with and learn from. I've certainly learned a lot. Many of you had suggestions for the research that we need, and I wanted to list these out in case maybe some of you, we have over 500 people on the call today, want to take any of this on. We need it. Um, we need to understand the impact of our interventions going all the way back to antenatal care. Specifically, what are the outcomes on pregnant women? How are moms affected by some of the things that we do? Some of these are technical surgical interventions like delivery method. Um, it's also our counseling. We recently finished a study that showed that a minority of the families that we engage in antenatal counseling go on to deliver. Um, we need to understand the impacts of these things and how to do them better. We need to go back to physiology. What's happening to the skin between 20 and 25 weeks? How does the respiratory system change? Meconium is a really interesting conundrum that many people bring up. How gut motility and integrity relate to that and that first passage. It's a really tricky subject in these group of babies. Our next webinar will be on hydrocortisone and adrenal insufficiency, but I think broadly there's a lot of physiology that we need to better understand there. Certainly neurologic development is important and sensory development. Epidemiology is important. One thing we do have in this area is a lot of hospitals reporting their outcomes. We have a 50% survival rate. We have this. But we need more than that. And we need really, I think, a big gap that we have is what's going on after the NICU. Yes, for the patients, but also for the families. Lots of management questions came up. They start in the delivery room and they go through the entire NICU stay. I've listed a few of them here that are common and that we think are important. So, how do you deliver the baby? What's the best approach? The majority of babies at this age haven't flipped yet. They're not vertex, they're breech. How do we accommodate that? That changes throughout gestation. Delivery room care is really important. Lots of basic questions that we better understand for older babies. We haven't done these studies for babies this early. Is it the same management? I don't know. Nutrition is a huge issue. There are important differences. The third trimester is a lot of time that these babies miss in terms of accreting things like calcium and phos. Feeding advancement may be different. I don't know. We need to find that out. Hyperglycemia is a very common issue that people ask us about. We're trying to learn a little bit now about environmental temperature and humidity through the humidity study, but there's more to do. Skin antiseptics are a common question. Positioning. We have a collaborating group in Australia who just got funded looking at midline positioning. I'm very excited to learn from them in a few years. Respiratory support. We also need to think about interventions after the NICU. Some of you probably know that half of our babies who graduate from the NICU at 22 or 23 weeks, in some of the epidemiology that we have, are rehospitalized in the first 2 years, frequently for respiratory infections, frequently in an ICU. Can we prevent that? What are the things that we can do to make sure that that doesn't happen? I don't think that that's anything that any of us desire. So what I hope you hear from our talks today is that if you're a clinician, you probably recognize if you're on these webinars that there are some important differences in physiology and management in the most immature infants. But we're asking you, please make sure these babies are enrolled in your research protocols. It's the only way we'll learn together. Please make sure that we have follow-up after they leave your NICU. It's the only way we'll learn together. Try to join a collaborative. The issue of small numbers is a big one. You can benchmark. If it's a local collaborative, if it's a big one like ours, we'd be happy to talk to you about that. But only by pooling our resources can we learn. And please keep engaging with your families to ask what they need. If you're a nurse or a therapist who's on the call today, we hope you recognize that these babies are different. They may need different nursing or therapy protocols. We'd love to engage with you in this. Please also support enrolling these babies in research protocols. I know that when I talk to a family about research, the first thing that happens when I leave the bedside is that the parents look over at the nurse who they know and they trust and say, hey, you think I should do it? Should I enroll our baby? We need your support and we need your involvement so that we can do these studies right. And thank you for all that you do for families. We need your help to continue to engage them. If you're here from industry, you'll hear a little bit about some of the products that we're just lacking. This is this is kind of the story of neonatology, but right now for tiny babies, we're adapting to products made for bigger babies or more mature babies, and it's not right. We need things that accommodate the small size of the face so we can provide non-invasive ventilation. We need adapters for the jet ventilator that fit our 2O tubes. We need to make sure that we have a Nava catheter that isn't too long because our babies are too small and it would pass the stomach and doesn't fit. If you're a researcher, thank you for what you do. Please keep enrolling tiny babies in your studies. Consider specifying in your analyses that this is a different group. Try to separate them where you can. Do a statistical test. See if there's a difference. And keep asking families what they need. That's how we progress. And so with that, I'd like to turn this over to Dr. Peart, who's going to talk a little bit about her initiatives in Melbourne, Australia. And then we'll follow that with a discussion from Professor Battersby in the United Kingdom, and she can describe what she and her group with Dr. McDermott are doing. Thank you.
Thanks, Matt. Can I just get a quick confirmation that you can see my slides okay?
Yes.
Fantastic. Thank you for the invitation to come and speak at this really exciting, I think, really important webinar for tiny babies. So I'll touch on some of our local changes that we've made here in Victoria regarding the provision of survival-focused care for infants born at 22 and 23 weeks. This will include some discussion about our local collaborative and really then just focusing on the research efforts that have been made to try and address this tiny baby cohort. So really just to orient you all, given that we're coming together from across the globe today, so I'm speaking to you from Melbourne, Victoria, and at this state, this is where our 5 neonatal tertiary units are all located. Now, Victoria's a pretty big place. It's about 230,000 square kilometres, so it equates to about the size of the UK. We've got a population of around 7 million people, and we see about 75,000 births per year. Now, back in 2020, COVID wasn't the only thing that changed the face of Melbourne. We also entered a new era in neonatology, offering survival-focused care to infants born at 22 weeks. And this followed the introduction of our Safer Care Victoria guideline, which essentially advocated for that zone of parental discretion to move 1 week earlier, so extending from babies born at 22 plus 0 to 23 plus 6 weeks. And this essentially meant that discussions regarding survival-focused care were based on a shared decision-making model between families and healthcare providers, ultimately with family wishes being respected. There were a few criteria set out in our guidelines, really to optimise circumstances surrounding birth. This included being inborn with a complete course of antenatal steroids on board and free from any major antenatal complications such as congenital anomalies. So it's been a few years, and what have we seen since those guidelines? Well, we've seen that the proportion of families opting for survival-focused care at 22 weeks has remained fairly stable at about a third, but we've seen an increase in those wishing for survival-focused care at 23 weeks. In terms of survival rates, this is some aggregate data from our 3 perinatal centres in Victoria, and albeit still fairly small numbers, we're seeing survival rates of almost 60% at 22 weeks and just shy of 70% at 23 weeks. To note, this does also include our outborn infants that are transferred in as well. But it's a far cry from what was originally purported in those Safer Care Victoria guidelines, which really only estimated survival at 22 weeks to be between 20 and 40% at 1 year. So perhaps we have made some progress over time with experience. Now, I don't have our aggregate data for 2024 and 2025. I think it's due in the next couple of days, but I have got some data just from one of our sites, so Monash Newborn, where I work, so very, very small numbers at one single site. But we're seeing in the last 2 years that survival rates for infants at 22 weeks have averaged out to be about 83%, and maybe just above 60% for those born at 23 weeks, again, including outborn infants as well. And we've got a couple of patients who are still inpatients at the latter end of their NICU journey. Casting the net a little bit wider to our colleagues across Australia and New Zealand, this is some of our ANZ data, which demonstrates that rates of live-born infants born before 24 weeks has remained fairly stable across the last few years. we've seen a slight uptick in survival, and that's averaged out to be about 50%. But to note, currently ANZ don't separate out 22 and 23 weeks individually. And of course, not all units across Australia and New Zealand currently offer survival-focused care at 22 weeks. So speaking now to some of our local collaborative efforts, for a long time now, we've had our Victorian Infant Collaborative Study, or the VIC study, which is led by Professor Jeannie Chong. And this was established way back in 1979, so decades worth of data. It's the world's largest longitudinal program of research that conducts observational studies to track the long-term outcomes for infants born extremely preterm. Cohorts are recruited in distinct birth eras here in Victoria, with all units contributing data for all infants born before 28 weeks or less than 1,000 grams. And these infants are then matched with term-born controls. Impressively, follow-up continues into early adulthood, so often into their early 20s. And this has resulted in a remarkable number of publications, which has really helped to contribute to our overall knowledge of the long-term outcomes for these infants born extremely preterm. But of course, it's not specific for just the tiniest babies. However, I do want to highlight that this group are now reporting on and really addressing these infants as a distinct cohort, which I think is a really positive step. And I'm sure we'll see similar studies coming out in the coming years. But now just to turn the lens just to the tiniest babies. So following the introduction of those Safer Care Victoria guidelines, we formed our local Victorian Extreme Prematurity Collaborative. This includes all 5 of our tertiary neonatal units. Currently, 3 out of 4 of our perinatal units offer survival-focused care at 22 weeks, the latter due to start soon. And our 5th unit is primarily a neonatal surgical unit. We meet regularly, and we do have representation of people with lived experience on our steering committee. And really, this came about because we recognised that we can't do this in isolation. Individually, at each unit, these numbers of babies are remarkably small. And so in some ways, we're learning our way in the dark as we continue to care for and learn from these tiny babies. So this was really an exercise in data benchmarking, sharing what we're doing and what our outcomes are, hopefully with the aim to stimulate some quality improvement initiatives and ultimately to standardise best practice care for these babies. And we do have 4 of our sites also pursuing involvement in the mini study that you heard Matt just mention in order to help contribute data on a global scale. So I was then asked to discuss some of the research that I've been involved in with regards to the tiny babies, and really addressing this underrepresented cohort has been one of the main focuses of my PhD. And this was the paper that Matt just referenced, which really does demonstrate that this group of babies are an underrepresented cohort, with only about 1% of infants included in RCTs since 2010 being born less than 24 weeks. And so this really prompted us to consider, is it appropriate then to use the same clinical practice guidelines for the tiniest babies? So we reviewed 3 major international guidelines, the AAP perinatal guidelines, the European consensus guidelines for RDS and ILCOR, and we identified any overlapping recommendations. So these are really common things such as antenatal steroids, deferred cord clamping, initial oxygen to use at resuscitation, surfactant, etc. And for each recommendation, we reviewed the references which were cited as being the evidence base for that recommendation. We then analysed each study individually to ascertain the proportion of infants included who were born before 25 weeks gestation. So in total, we looked at 519 studies, which recruited just almost 410,000 infants. And we found that within RCTs alone, an estimated 7% of infants were born before 25 weeks. And whilst this number on its own may seem maybe okay, a lot of these studies were exclusive just to extremely preterm infants. So in that case, we would expect the proportion of infants born less than 25 weeks to be something around 25%, so not entirely as representative as we would hope. We also saw a large number of RCTs at just over 40%, not including any infants born before 25 weeks. And even in those that did, they did so in really small numbers, with medians of only about 1 to 8 infants. So it seems from this that we can't simply just extrapolate the evidence for more mature infants and assume that the same safety and efficacy applies at those lower gestational thresholds where the evidence is clearly lacking. And so this really highlighted to us the urgent need for studies that start addressing these babies as a distinct cohort. But in an evidence-free zone, where to start? You could perhaps choose any area of clinical management, study it in a randomised way, perhaps using the same outcomes we're used to seeing, such as death, BPD, IPH, etc. But we all know that time and resources are finite. So what is the most pressing question or area of knowledge that we need to resolve for these babies? Well, we thought it made sense to go straight to the source. So we partnered with those with lived experience. We know that in order to meaningfully improve outcomes for these infants and their families, it's important that, or it's critical that we first establish what the priorities are for those with lived experience in this space. And really, by engaging early, right from the start in that research development process, it enables us to open a dialogue. We can learn what is relevant, what is impactful, and that ensures that we ask the right questions from the get-go so that the research that we do conduct hopefully translates into a meaningful output. And it's really this consumer engagement which underpins the James Lind Alliance. So the James Lind Alliance is a non-for-profit UK organisation which brings together people with lived experience and healthcare professionals to ultimately decide what are the most important areas for research in a particular given topic. And it's with this in mind that the Most Premature Babies Priority Setting Partnership was formed. This is an in-press initiative, which is a collaboration between the Murdoch Children's Research Institute here in Melbourne and the University of Oxford's National Perinatal Epidemiological Unit in the UK. And the aim of our PSP was to jointly identify the most important areas for research for infants born before 25 weeks gestation. We used standard JLA methodology, which essentially is a Delphi process that included online surveys and a workshop. And it's really important, I think, to note from the beginning that the aim was not to come up with really clean, crisp PICO questions that could be taken straight to funding bodies, but rather to identify the broad areas of research, which researchers could then drill down into. So we designed and disseminated an online survey inviting respondents from Australia, New Zealand and the UK to simply tell us, what do you think are the 3 most important questions regarding infants born before 25 weeks? And we purposely kept this really open and simple so as not to limit respondents. And again, we weren't asking people to submit specific PICO questions. We then engaged with 15 partner organisations representing preterm infants and their families to help share our work and really reach those with lived experience. All questions that we received then formed summary questions by grouping together those questions with common themes. And so, for example, here on the left, you can see a lot of questions about infection and sepsis that ultimately formed a summary question of how can we prevent infections in babies born less than 25 weeks. All summary questions then underwent an evidence check to determine if they had already been adequately answered by the current literature, and this was limited to systematic reviews published within the last 10 years. All questions which remained unanswered were then taken through to a second prioritisation survey. This invited respondents to select their top 10 most important questions from that list of unanswered questions. We wanted to ensure that our results weren't skewed simply by the greatest represented group, so we also ranked individually according to each respondent category that you can see here, so healthcare professionals, parents and carers, and adults themselves born extremely preterm. We then combined those individual ranks to obtain our overall top 19 ranked priorities, which were taken through to our final priority setting workshop. This workshop was attended by 30 participants from across Australia, New Zealand and the UK, with equal representation of all our key stakeholders. And together, working in small groups, they really shared, discussed and ultimately prioritised the top 10 questions. We then combined each small group's results to obtain our final top 10 list of priorities. Running through this fairly quickly, we received 311 responses to our initial survey, which yielded 844 questions, 706 of which were within scope, and went on to form 81 summary questions. 80 of these 81 summary questions were unanswered and went through to our second survey, of which we had 455 responses that ultimately formed our top 19 list of questions that went through to that priority setting workshop. Just a note to say that our demographics were slightly unbalanced, so something to keep in mind when generalising this to the broader population. Perhaps unsurprisingly, the majority of our respondents were healthcare professionals. We had greatest representation of females and those from Australia and New Zealand. We saw a greater preponderance of those with a Caucasian ethnicity and of a higher educational level. But these essentially were the top 10 priorities. So coming in at number 1 and fairly broad was what can be done in the neonatal intensive care unit to improve long-term health and developmental outcomes. How can we improve the care of babies at delivery and in the hours after birth to improve outcomes? What is the best way to prevent brain injury, including IVH? What interventions or treatment during pregnancy and labour can improve outcomes? What are the long-term outcomes and how are they best predicted? What is the best way to manage pain and distress? What is the most effective postnatal steroid treatment regimen to improve outcomes? What is the best way for families to be more involved in the care of their baby? How can antenatal counselling be improved for families facing the possible delivery of a baby born before 25 weeks? And how can families be best supported during their baby's NICU admission? You'll note that we don't specify specific interventions or outcomes, and this was a purposeful decision. One, simply from a pragmatic view that it would be unwieldy to tease out every single specific question that we received. And also in line with JLA methodology, it's really about identifying those broad categories of research. You'll note here that there's a lot of consensus amongst the 4 groups in terms of what were those top 10 priorities, which I think was really reassuring to see. And taking you back a step slightly now, this is our top 19 ranked questions that we had from that second survey. And I really just wanted to highlight here that we see a lot of consensus and a lot of shared priorities between healthcare professionals and those with lived experience. In fact, the top 7 were all the same, albeit in a slightly different order. Also, while not depicted here, the discriminating value between each rank, so often with only one response separating a ranked question, really demonstrates that all of these priorities, I think, are important to our key stakeholders. So we were really pleased to see that this final top 10 list was so varied and holistic, and I think it really does reflect the complex and the nuanced needs of these infants and their families as a unit. It certainly did highlight the importance of engaging with people with lived experience. So we saw a lot of questions, particularly those surrounding parental impact, support and involvement, ultimately being ranked higher following that workshop. But of course, as always, there's more work to be done if we're going to move research in the direction to really identify this group as a distinct cohort. I think we can all appreciate that this is still a relatively small population in whom obtaining prospective consent can be really challenging. Often the events surrounding births at this gestation are extremely stressful and complex. And that's why I think we are so reliant on that national and international collaboration if we're going to recruit really robust and representative sample sizes, which we need. One other point I think I do want to highlight, which may present as a potential hurdle, is I think the perception that this group is seen as too high risk in terms of their morbidity and mortality, perhaps by researchers or ethic review boards. And that study that both Matt and I referenced earlier by Pavlik demonstrated that in studies that were exclusively enrolling extremely preterm births, only 37% actually even permitted infants born less than 24 weeks to be included. So I think if we're going to move the needle here, we need to move away from the perception that these infants are too high risk to be included in the studies that for that very reason they may benefit from, because currently what we're doing for these babies is simply not evidence-based. So on that note, we would encourage researchers to avoid lower gestational age cutoffs and to stratify subgroups according to those born before and above 24 weeks. In the meantime, while we await those really robust RCTs, large database registries such as the mini study, which Matt has mentioned, are critical, I think, to really observe and learn from this group of babies. And I think considering alternative research methodologies is needed, perhaps things like qualitative research to address some of those really equally important priorities that we saw, perhaps getting a little bit more creative with our study methodologies to really increase trial efficiency. So really, we think our top 10 list should be considered just a basis on which to then further develop some focused research questions. We would encourage researchers to use these results as a voice for advocacy when commissioning funding bodies to implement studies that improve relevant and meaningful outcomes for the most preterm infants and their families. In terms of next steps, well, we've really used this PSP as a springboard. We've now formed a couple of small subcommittees that are addressing a couple of those top priorities. And within these subcommittees, we have experienced neonatal clinicians. We have those with extensive experience in running really large multi-centre randomised trials, trial coordinators, and of course, importantly, those with lived experience. And together, we're working on developing specific PICO questions that can then hopefully be taken through to a randomised trial. And I think key to this, as I've mentioned before, and I'll say it again, is really embracing those international collaborative efforts because we really do need your help. I'll leave you with one final, perhaps controversial thought, which is, should random care be randomised care? So in an evidence-free zone, where clinical practice varies and equipoise exists, should all infants born before 24 weeks be automatically enrolled in comparative effectiveness trials? So studies which are comparing really common therapies considered standard everyday practices of care, but which vary considerably across the world because we simply don't have the evidence to know if one is better than the other. I'll leave you with that thought. I'm going to wrap up there. Thanks for listening. I'm very happy to answer any questions at the end.
Great. You let me know if you can still see them.
Those look good.
And excellent. So thank you everyone for joining. It's really exciting to be at an international conference where we have people from the US, Australia, I know it's really early over there, and UK here as well. I know many of you on the call, it's the evening here. In the next 20 minutes or so, Helen and I will tell you and share our experience of using research to inform the management of our babies born extremely preterm, focusing on those born at 22 weeks in the United Kingdom. I want to start off by just giving you some context because I realize that many of you are from different parts of the world, and I'm sharing our experience here in the UK. And it's really important that the research we do is really applicable and feasible for your own local setting. And I'm an absolute believer that every local centre should be doing research. Every country should be doing their own research. Because we have different healthcare systems, our neonatal services may be organised differently. We have different resources. There was a question in the chat about staffing ratios. That is a reality here in the UK. We don't have a limitless pot of resources, and we sometimes have to make difficult decisions on how we organise our care. There are also different cultural and societal factors across the world. We're really fortunate in the UK. We have a really collaborative and national approach to, for example, developing guidance. And I'll be talking a lot about the British Association of Perinatal Medicine, of which I'm honorary secretary. And this is the professional neonatal organisation in the UK. And also the UK Neonatal Collaborative. We are a really strongly embedded data culture in the UK. So we submit to national audits and research. So we've used a very national approach to address this issue here with our very small babies. And as Matt and Stacey have already said, the reason is because for us in the UK, every unit will only see 1 or 2 or maybe less than 5 to 10 babies each year. So we really need to be working together as a population level in order to learn more about this population of babies. So just to give you some context, in the UK, we're a national health service. So we're a nationally funded health system. And it's really important to understand that because we organise our care within networks. So we have an annual birth rate across the country of 700,000. We have around 200 neonatal units offering different level of care here. The diagram below here, you can see there are 3 different levels. Neonatal intensive care units offering the highest intensity, and they are distributed in 14 geographically defined networks. And the idea is that babies are transferred between units in order to receive their care. Just to give you some context, we have about 80,000 babies admitted to our neonatal units each year. And just alone in England and Wales, we have around 8,000 born less than 32 weeks. So in the 2019, the BAPM developed this extremely preterm framework. And essentially, it changed from no resuscitation for babies born at 22 weeks to recommending a risk-based approach using 3 factors. So not just gestational age, but also non-modifiable risk factors and the modifiable risk factors such as where the baby is born and where the baby received antenatal steroids. Babies are then categorized into 3 risk profiles. And this is the risk of developing a poor outcome, which is defined as either a mortality or a severe impairment in later life, including neurodevelopmental impairment that affects your daily living. So there are 3 categories. Extremely high risk is if you have more than 90% chance of a poor outcome. High risk is if you have 50 to 90% chance of a poor outcome. And moderate risk if you have less than 50% chance. But clearly, in order to define these, we actually need the data to tell us which babies have these risks of a poor outcome. And this is where it lies important, the data that we collect. I will talk to you about that later on. I just want to draw your attention to this framework here, this flowchart, which is very commonly used by our clinicians. And if you're extremely high risk, the recommendation here in 2019 was that life-sustaining treatment should usually not be provided and to confirm management with parents. Embedded throughout the framework is a very shared decision making with parents, and it's important that that continues in all our frameworks. So what was the effect of the national guidance? In 2023, we looked at the data around the period of the introduction of this framework in England and Wales. And we brought together a large national neonatal research database with data from babies admitted to neonatal units and also from Embrace, which is data of babies in the labour ward. And by bringing these data together with the right denominators, we were able to tell that there was a threefold increase in babies provided survival-focused care born at 22 weeks, which is a blue line at the bottom, rising to around half of the babies, and no change in the 23 and 24 week, as almost universally above 90% offered survival-focused care. When we look at the survival rates here, comparing two epochs of 2 years each, you can see here that the survival rate was 2 out of 10 for those receiving survival-focused care. And even though the numbers are higher, the last epochs, the survival rate for those admitted to neonatal care was 3 out of 10. So still very high mortality rates. And you can see here for those, the BDIs, that our survival rates did not improve between the two cohorts. And the reason is, when we looked at the data, was that neonatal teams around the country weren't actually implementing what was actually intended in the framework, which was a risk-based approach. And we could see here that the most recent epoch had a high proportion of babies born at the earlier part of the 22nd week, and there was a high proportion born less than 500 grams. And we were hearing from colleagues around the country that actually this was a huge shift in their management. And the framework itself, they thought, could be improved with a bit more clarity with the wording, and there was a varying interpretation of it. So what can we learn from these research findings, which are really important to see the impact of national guidances, is that clearly this has a resource implication that we are seeing a threefold increase in the numbers and proportion of survivors of 22 weeks, but also those receiving survival-focused care. What does this mean for our actual neonatal service? We also have these numbers here. I'm not going to repeat them again, but these are really important numbers for our counselling. And we compare these to our babies born at 23 and 24 weeks. How can we improve these outcomes? And perhaps a lack of improvement in outcomes is to do also with the fact that teams are practicing a universal versus a risk-based approach, and that there was varying interpretation of the guidance. Really importantly as well, we found that those I suppose as defined as outborn, born in the non-tertiary centres and transferred to NICU had a high mortality rate, almost 90%. So how can we improve the outcomes, and do we need to centralise care even further, were questions that we asked ourselves in the UK. And through many different forums of discussion, we developed 3 strategies that we thought we would do first before we decided whether we needed to centralise care further. The first is to update the BAPM framework with a bit more clarity with what is intended. And I wanted to say here, it's so important about the language we use. And we're really lucky to have Professor Wilkinson on our framework development committee. But it's actually really important we use the right language and sensitive to parents as well. The second is that we wanted to share knowledge and experience across the country. As you see, there are many, many units. And the BAPM has since developed a new specialist interest group called Nana Preterm. And the third, which you'll hear more about, is we need to have national research collaboration within the UK across our sites. And you'll hear more about the 22-week study and longer-term outcomes. With these 3 strategies, we hope that the survival rates will improve. And from hearing many experts in other centres across the world with really good outcomes, the consistent message to us is that the belief of hope and survival is really important in order to improve our survival rates. We need to believe and see babies surviving. And at the moment in the UK, the survival rates are low. And we need to improve those by selecting the right babies. And then in the future, when we learn more about these babies by working together, we hope that obviously we will look after more babies born at 22 weeks. But this is the current state for us in the UK. We really need to be learning more about this new population of babies. So the first strategy, as I said, is to revise a framework. And I just want to thank and acknowledge all those who contributed and really supported me as the chair of the framework. I'm also really delighted to share that literally on Monday, we published this online. There were over 280 comments that came in. We responded to each of them. And there's a summary of changes as well on the website that you're very welcome to visit. And the BAPM works by putting these frameworks out to consultation. This is very much a collective effort nationally, working with our neonatal teams across the country to develop these guidances. So actually, we've incorporated much of the feedback, and I hope that you'll find these helpful. I'm just going to illustrate some of the nuances in language that we've changed in the guidance. So this is a follow chart that many use. And we were told that this was quite ambiguous, quite grey about the life-sustaining treatment usually not being provided. So we've actually just changed the wording for the extremely high risk with more than 90% chance of mortality or poor outcome is that comfort-focused care should be provided, and explain the management plan to parents. We've also had recommendations for those born in non-tertiary centres prior to 23 weeks that these babies will be considered extremely high risk and that comfort care should be recommended and that transport should usually not be appropriate. But also really highlight the importance of communicating between the tertiary centres and the non-tertiary centres and transport teams, and also really an honest conversations with parents as well. We also at the back have collated many example scenarios that we've been shared by many colleagues around the country. We've got over 20, I think, and we hope that these scenarios will be really helpful because they're real. They weren't just made up by us. So we hope that these are helpful too. The second strategy is developing a real community, multi-professional communities around the country that we can come together and just like Australia and various other places around the world and the US to come and share cases, but also do research together. So by open election, which is what we always do in BAPM, we appointed a steering group here. These are the officers and they're also regional representation clinically across all networks and also specialists. And together we are about 40 of us. And then we have a wider over 600 colleagues who've signed up to join this group. And this year we're going to go around the country virtually to hear about cases, but also to explore facilities and barriers and really coming together to learn more about this population and supporting the 22-week study as well. So the third strategy is to come together to actually learn from every single baby born at 22 weeks. And just like Stacey's mentioned, it's really important to align with the research priorities of excellent work that she's done. And we believe that our research aligns with some of these that she's mentioned. So as highlighted before, they're small numbers, and we think the study addresses that by coming together. We have nearly 50 sites. The importance of granular data collection. So I've spoken about routine data collection on the National Neonatal Research Database. Unfortunately, the routine data we collect are just not granular enough for us to learn. And you'll hear more about from Helen about the detailed data collection we have in the 22-week study. And really, you've heard also about the challenges of funding and data collection. And we're really fortunate in the UK that our resident doctors are extremely enthusiastic about research, and NeoTrips, which is affiliated with BAPM, are led by our resident non-consultant doctors. We have representation across the country and they're collecting the data with their consultant support. So a really great opportunity for them to get involved in research and develop their leadership skills and contribute to a national study. And the other challenge you've heard from Matt and Stacey is the ethical approvals and that conundrum of parental consent. And we certainly co-developed our protocol with parents. And we hear from them as well that it's extremely emotional time, incredibly burdensome to yet sign more papers when actually they really believe in the research, but it's just not a good time. And considering we're not collecting identifiable data, that they would be very happy for the data to be used. So when we put this through research ethics, they were actually very pleased with us just having a parent information leaflet, no formal consent needed because we're not using any identifiable data. So that's really supported by the Research Ethics Committee. The information leaflet we have is translated in multiple languages and is on our website as well. So the overview of the 22-week study, it's an observational study where we want to describe the clinical care and outcomes of babies born at 22 weeks across the UK, and also start to explore factors that influence outcomes. Importantly, these observational data can then be used to develop hypotheses and actually inform the design of future interventional clinical trials or other further research studies. So we co-developed this with many colleagues across the country, and also presented at the BAPM conference. It took just under a year to set up, and we gained ethical approval, and it took a while to get all the ethical approvals and R&D for each site. But really want to thank Helen for her tremendous work. And importantly, it was all co-developed with parents as well. So here's a slide that really reminds me to just congratulate Helen, which you'll hear from her later on, to have England, Wales, and Northern Ireland involved, and hopefully Scotland as well, is a tremendous achievement. And we've heard earlier on about the importance of having many centres join, but for us in the UK in particular, because of how our services are designed, it doesn't make sense to do single centre studies. Our services involve a collective experience, and therefore having us all join in is really important. There are only like 2 or 3 units who weren't able to join because of R&D limitations. So thank you to everyone who's joined the study. You can see here there are 42 units open and nearly 50 sites already signed up. And we have at the moment 50 babies included, and obviously that's just half a year, so we hope to have more. Thank you, Helen. Well done. I'm going to hand over to Helen McDermott, my kind of research fellow, and she'll tell you more about the preliminary results of the 22-week study. Thanks, Helen.
Okay, thanks, Cheryl, so much. So I'm really excited to be able to share some of the early results and future plans and hopes for what we will be able to report from this study. I will note they are still early. We've analysed some of the results for the webinar, and a lot of our babies are still within their neonatal care admission. So to begin with, I'll talk to you about the unit level data, and this is being presented at PAS. So if you are going, please come along and learn some more about this. But so 36 of our units out of the 39 medical and surgical centres have reported this so far. And one of the first questions we asked was about whether the unit had a guideline specifically for babies born at 22 to 23 weeks gestation. And we know that there's a national and lots of local guidelines for under 28 weeks. But what we found from this was that less than a quarter have a guideline specifically for these tiny babies and their management. We then also asked about whether there was an agreed departmental consensus on approaching a baby and a mum at 22 weeks antenatally and then around the time of birth for stabilisation. And just over 60% reported having an agreed consensus within their department, and the majority of those were based on the BAPM guidance. So each baby is assessed individually using those risk factors and then to follow that. Some have a slightly more universal stabilisation slant to that. Others have quite strict BAPM kind of criteria using that, but overall consensus in 60%. We know that the mortality is high, and so we also asked about whether there was a dedicated neonatal or paediatric palliative care service available, either remotely or on-site to support. And 70% actually have access to that, which is great. We then asked about care practices, and without going into too much detail, we found lower variation, much more consistency around cardiorespiratory care. So we don't seem to be doing routine echoes on preterm babies at 22 to 23 weeks in the first week of life to direct the hemodynamics management, for example. We have higher variation in practices around fluids, nutrition and feeding. So a starting fluid, for example, volume somewhere between 60 to 120 mils per kilo per day. We then asked about issues with sizes of equipment or availability, and a lot of this came through on the information we got from the audience prior to this webinar, so I'm sure this resonates with a lot of you. The issues with sizes of airway equipment, so particularly the size of the direct and video laryngoscope blades, ET fixation methods of that, and suction catheters that don't necessarily interact with the smallest ET tubes at 2 millimeters. The next thing was about non-invasive ventilation, so CPAP and high flow masks. So the interface is not being small enough for these babies to get a good enough seal, meaning that they have to have longer invasive ventilation times. Issues with central line availability of the sizing, and lots of information about skin and concerns about skin treatment. So things like silk or bamboo sheets, what sort of monitoring. And this was mentioned earlier, but in the UK, our growth charts and phototherapy treatment charts for bilirubin, neither of those have a line for a 22-week baby. The lowest gestational that is recognised with recommended treatments for that is at 23 weeks. And also lab values, these lower gestations are not included in the values that we look at. And they're the highlights from the unit data so far. So I'm going to tell you a little bit about how we've collected the baby level data and then just some trends and some highlights from what we have so far on this. So as we've talked about the design, so it's pseudonymized data collected prospectively and goes onto a REDCap database of 22 weekers admitted alive to NICU or with a neonatal team present at delivery in order to capture that small group that have an unsuccessful stabilization in the delivery room, which our national teams really wanted to look at. We estimate around 100 patients may be able to be involved in this, but each unit may only have 0 or 1, under 5 or under 10 babies per unit. So this is how the timeline works for the data collection. So after the baby is born, there is daily data collection for the first week of life, which is very intensive. And then after that, it is weekly from week 2 onwards, with the end point being discharge or death, the end of the NICU admission. The patient leaflet is given, and this all goes on to REDCap. So to give you an idea, the ITU management box is what is collected daily and then weekly. And this is where a huge amount of the very hard work from our data collectors has come in. It is extremely granular and detailed. The other aspects, so demographics, counselling, antenatal information, delivery room and outcomes are single forms. And what we did do before we finalised this and started was speak to the Tiny Baby Collaborative mini study, who very kindly shared what the categories that they collect, and we've aligned as much of those data points as we can locally, because it's really important that we manage to be able to aggregate or compare these categories accurately when we're collecting this really precious data. So our planned analysis and output, so the results are expected late next year. This is a 12-month data collection period at present in order to capture the numbers. We hope to really describe this population in detail with the demographics, their interventions, and the causes and decision-making around their deaths. Looking at the description of clinical interventions at a time point and longitudinally, and this variation and concordance amongst unit practice, which is going to be so important for UK guidance and also to compare to international practices. And we hope to explore the predictive markers for outcomes and these lab values for things like platelets, creatinine, bilirubin, sodiums, as to what's happening to these babies ex utero. So as I said, these are really small numbers and babies are mainly still in the neonatal care period. But as we get more, we're starting to see trends in the demographics aligning more with the BAPAM guidance risk factors. So towards the end of the gestational week and higher birth weights now starting to come through as a pattern. One of the things that has surprised us is that the median age of death is actually later than the first week. So we really focused our attention on that first week, but actually the median age is just after that at the moment. But we do have detail on deaths, which we do not get from any of the routine data about reorientation to comfort care. The majority of these seeming to be from hypoxia and hypotension refractory to intensive care. And the fact that post-mortem or autopsies are being offered in a high number, but very, very few are being taken up at present. And this is an idea of the daily data and what we can do. So you've got your care interventions on the left and then the days of the first week along the top for babies who have completed a full week with high percentage numbers in red and 0 in green. So you can see here in the UK, the majority of babies are being volume ventilated, very few having high frequency or pressure. We're giving surfactant mainly in the first 24 hours and certainly not after 72 hours, which is different to some of the international practices we've heard on some of these webinars. About half are receiving postnatal steroids, and the majority of those is hydrocortisone for BPD prophylaxis where they're given. Aligning with the unit questionnaire, a very small number are having echoes in that first week, and that generally seems to be targeted where there's concern rather than a routine. Inotropes received very small numbers again, but we seem to be using dobutamine and dopamine, but at very, very small numbers. And as you can see, we nurse here in high humidity, so the incubator humidity around 85–90% most of that week. And then really excitingly, one of the things we can look at is something like this, lowest platelets or highest creatinine. Each dotted line is an individual baby, and then there's the median and interquartile ranges, just to give you an idea of the first week and then the second and third week of just what this looks like for a larger number of babies rather than the one we see when we wonder whether this is normal or not or concerning. And so the further outlook, so this is a huge, huge collaborative effort. We sit here, but there are hundreds of people data collecting and doing the really hard work, which we're so appreciative of. And they are all on our website at the bottom and also on the next slides. It's really important to analyze this data further and then bring these data sets together as much as possible, so that to kind of overcome this really small numbers so that we can learn together. And our more information and contact details are there. So there's so many people to acknowledge, so I'll briefly go through this, but Chelsea, Imperial and Neotrips, as well as the parents that have contributed. And then this just gives you an idea of the number of people who are data collecting, and a big, big thank you and well done to them. And I'm going to hand back to Cheryl.
Thanks, Helen. This is just the final slide to remind us reminder of Stacey's first highest priority from parents, which is looking at longer term outcomes. And I'm delighted the NIHR have also recognised that. And my fellowship is focused on looking at long term outcomes, linking the neonatal data to longer term health and educational outcomes of the Neo Wonder programme. And we have linked for the last 14 years, babies less than 32 weeks, around 80,000 babies, to their health and educational outcomes. So I hope to be able to present more data in the future. The final slide here is what are my reflections, and thank you, Matt, so much, and to the Tiny Baby Collaborative for this really important webinar. And I hope that we've collectively demonstrated how important it is to use research to inform our national guidance, and it needs continual research because these things will change, and the importance of data. Really important to collaborate internationally, and it was great to have met Matt at the PAS conference and also Erica from Vaughan, to come together to prospectively design these data sets so that they align, and hopefully we can bring them together and do some collaborative research. And finally, we really recognise this in the UK, and the BAPM has this in the framework, recommending units who care for extremely preterm babies that they should be participating in audit and research, and particularly for any unit looking after 22 weeks. I actually think it is should be mandated. I think it's a responsibility for a new population we don't know too much about to conduct research and contribute data to local, national and international studies. So I'm going to end on that note on thanking all everyone who contributes to the neonatal database, the 22-week study, Neotrips and the BAPM and our funders. Thank you very much.
So I'd like to invite our moderators to speak, and I'll turn over here to Helen and the moderators. Thank you.
All right. Brian, would you like to go ahead?
Yeah, I'll ask the first question. Yeah, thank you to both of this, or all the speakers, and Matt for this great session. One of the major, I think, themes throughout everything in the population as a whole is how small the population is, obviously, but in terms of the numbers. And I wanted from both of you, and this matches up with some of the pre-conference webinar questions we got, and also there was a couple in the Q&A that also kind of is related to this. There's multiple levels to the sample size issue, but one just very practical question I'm kind of asking both of you, even with these observational data sets, what sort of challenges you had when a center is only going to have 2 or 3 babies in a year, right? It's going to be very easy to identify those patients. And so what pushback, if any, you had, or if there were challenges, and how that was overcame, or how you overcame it.
I think Helen's definitely been through that, and she's lived it and got the scars and the experience to share.
Yes, so we also felt that so the ethical review was really important in thinking about how identifiable these babies might be in small numbers, thinking about using data without identifiers, and then being really conscious about only reporting numbers that will not identify, so over 5, and not unique, and committing to that early in terms of having the numbers and thinking about what you need to collect to be able to get the numbers of kind of common things that are important to everybody. And then making sure you're working with your kind of data people in the university. So think about data sharing law. It's very complicated. There's just huge confusion, but also lots of technicality over it. And so I think getting that early and understanding what you need in your local area, and then if you want to go regionally or nationally, if there are differences, there are differences in the UK, which I have discovered, Scotland, Northern Ireland here, and working through those as early as you can, but thinking about your own data set to start with, and this aligning of data. But having buy-in is really important to overcome small numbers. You have to make sure that everybody is on board, and that you've got a project that everyone is willing to commit to, and whether that involves compromises at different points, but to make sure you have something that works. And then parents are just so important. You can't do any of this without kind of having their input and their experience. So listening to them around the consent process about what they want to know. As you know, Stacey's done a huge amount of work on that. But in terms of individual sharing, I think those would be the really important things in these small numbers to overcome when you're thinking about your own project or joining a bigger project, either nationally or regionally.
Can I build on Brian's question? I think that all of us have been working with preterm birth, which is 10% of the births. It's a pretty big population, actually. And we apply some of the same principles that we have all learned in banding together over preterm births to an ever smaller population. And I've heard many comments from the speakers about this sample size issue. What can we learn from other researchers who study rare diseases? They have to have all the same ethical issues of the rare case in your community, et cetera, et cetera. And is there an important mind shift and a cultural shift in our research to address it in that mindset? I'm curious how you guys would attack that.
So, Roger, I think that's a really good question. So I think Helen's downplaying it, but to get ethical approval has been quite a minefield. And I think what's really swayed it is we need to it's our responsibility to be able to communicate the importance of our research to the funders, to those who give ethical approvals, that is with parents, but it's educating them that this is a new population of babies, that actually internationally we have small numbers. We don't know what we're doing really. And how is it ethical? I turn on its head. How is it ethical that we're looking after these babies in small numbers in one single center and not knowing anything about what we're meant to be doing? How is that ethical? So the way we've actually written our ethics application is verging on that narrative. And you then win them over and going, oh gosh, this is, a real big problem globally. So how can we help you? Let's try and say, what can we do rather than what we can't do? And so, for example, we've limited the data. We don't have the data with the actual day of the month. We just have month and year. There are certain fields that we said we didn't really need that exact field. So we really worked with the ethical approvers to really minimize the data that we need to what we really need. And then for the consent process, again, it's working with parents. We still had quite a bit of pushback about not getting written consent because they were saying, like, these are small numbers, you can be identifiable. So again, it's that same narrative of parents don't want to be signing forms. So again, it's just being the advocate for parents. And I think they just need to be educated. I feel like as if when we do educate them, they come on board. But it's not having that dialogue in a really productive and positive way.
Cheryl, if I can ask a related question, you all did amazing work with the BAPM framework that just came out, last week. But I think it already acknowledged that the data needs updating, and of course we have data from all over the world with survival figures of 22 weeks that in other countries are higher and substantially higher compared to centers, including, the data that you had cited. And so I think my question is, how do we think about the lag time between what the leading centers in the world are accomplishing and how we can apply those data to national frameworks? And is there a risk that when we have national guidelines designed to prevent harm in a low volume center, of which there are many, do we inadvertently constrain the outcomes that could be accomplished in higher volume centers that are part of the same framework?
Yeah, no, I think that's a great question, Kashi. So we have had this sort of discussion about further centralized care. But the reality, as I said in my first slide, your national guidances need to be actually applicable to the country you're working in and how your neonatal services are designed. Even if we said, let's have all babies born in 22-week centers, let's get high volume. It just won't work because the ambulances bring it to the closest center. That's why we have a network based by geography. And it's just not practical. So in the UK, centralization, we actually calculated, won't be actually that resource intensive actually, but actually practically, we don't think it will work. We have trouble even getting beds for our 24, 5, 6 weekers, let alone, trying to concentrate all the 22 weekers in one center or fewer centers. But I think the importance is keep reviewing our data. And as I said, we have a risk-based approach. We have a different healthcare system to many other countries. I can't compare our outcomes to one single center in the US, for example. We have population-based data, and I don't think you can compare that directly to just a single center somewhere else that just looks after their inborn. So that's why in the appendix of the framework, we actually don't put things on graphs, we put them in tables, because I don't think they're directly comparable.
Can I extend that to Stacey as well about Victoria? Just because I think that this discussion is going to be very dependent on your geographic sort of setup. And I will say, looking at the map on the UK, there were a couple of sites that seemed like geographically very close to each other that made me think, are there localized opportunities for centralization? And so similarly, like with the map of Victoria, it looks like your major centers are all in one city. So has there been any discussion about the logistics of centralization or benefits of?
Yeah, thanks, Brian. You're right. Our centres are all fairly close together, sort of in metropolitan Melbourne in terms of our tertiary units. And so whilst part of our collaborative, we share our data, we share our outcomes, again, in a de-identified manner, but acknowledging that they're very small numbers, we don't have a formal database, and we're really still working on how to, I think, refine our data points so that we are collecting them in a consistent manner, and so they are comparable. But at the moment, it's still fleshing all of those details out.
But I want to come in there. I think your question about centralization, though, Brian, and having high volume is a real one, and we are continuing having those discussions in the UK. We even talk about pediatric surgical services, whether that should be centralized. So I think these are really important questions, and I think the key is to collect data, outcomes, benchmark, and keep reviewing your data.
All right. Thank you so much. Thank you to everyone who's joined today, to our moderators and speakers. I'll just close by identifying Dr. Manley's last comment in the Q&A about this concept of risk and partnering with our IRBs in the future and lived experience. And thank you all so much for setting such a strong example of how we can begin to do that. Again, this will be online, and we look forward to future conversations with everyone. If your question was not addressed today, please note we have saved them, and we will take them into account for planning our next webinars. Thank you all.